Good afternoon, Bill. So let me first of all give you an update on our first patient. There was an agreement and enthusiasm on the part of our surgical colleagues to help us with a hybrid implantation of the Melody valve. We've run into some logistics in terms of having enough team support. Normally we've got 4 cardiac surgeons. Today we've got 2. Jonathan Chen is doing an arterial switch right now. Lester by himself could do this, but he doesn't have an assistant, and pump standby was a little problematic. And the reason he wanted that is that this little girl, if you caught that in the initial presentation, had a really severe bout of mediastinitis at her initial surgery, and was really left with very little sternum as a result. When she had her 1.5 ventricle conversion here a few years back, she had a postoperative bleed that required re-exploration, and the cortex membrane, the substernal membrane that was there was taken out, and a material called CardioWrap was used, which is a collagen-based wrap that's used when you have diffuse bleeding on the surface of the myocardium. So with all those issues, our surgery team felt that yes, they're very willing to help us with a hybrid implantation, but they just didn't feel they had the resources to do that safely today. So we concluded the procedure, the patient's recovering, and we'll come back within the next few weeks for the hybrid procedure, the per-ventricular procedure that Alistair was advocating. We'll plan to do that as a taped case, and with everyone's consent, and Ziad, if that's okay with you, we will bring that to PICS next year as a tape case so people can see how everything turned out with her management. So appreciate everyone's patience watching us fumble around. The worst thing for me anyway is to come into a cath lab and watch somebody else struggling with catheter guide wire position, feeling like you have all the answers, and everything that was suggested were all great ideas, things that we had tried before we came on air, and John Cheatham was absolutely correct that the simple, straightforward, not so simple, but straightforward way to attack this is a per-ventricular approach. So that's what we'll do here in the next few weeks. So I've got Brian Moret, our newest colleague, and Troy Johnston here at the table with me. And I'm going to have Brian go ahead and introduce our next case.
All right. See the slides? So the case we have today is a 7-year-old boy who was born with critical pulmonary valve stenosis and a dysplastic tricuspid valve with multiple ASDs. He underwent balloon valvuloplasty when he was 2 days old, and his tricuspid valve regurgitation has remained moderate throughout the course of his life, and we have had 2 documented discrete atrial septal defects with no real symptoms or exercise intolerance. His physical exam consistently in clinic. He's been fully saturated. He's growing reasonably well. He's a well-appearing child. He has a holosystolic murmur and an early diastolic rumble, and the rest of his exam is otherwise normal. Next slide. His testing in the outpatient setting is EKG has demonstrated some right atrial enlargement and right ventricular hypertrophy, and his transthoracic echoes have pretty consistently demonstrated 2 discrete atrial septal defects, which you can see on the top image there, one more superiorly and one more inferiorly. The tricuspid valve continues to have moderate regurgitation, and the septal leaflet has quite tethered as a mechanism for the TR. Mild pulmonary regurgitation with no residual valve stenosis, and he continues to have moderate atrial enlargement and RV enlargement with normal function. Next slide. So the goal for today is to proceed with the transcatheter closure of multiple ASDs using the Gore Cardioform device with the assistance of intracardiac echo guidance and fluoroscopic guidance.
Very good. Thanks, Brian. So this was a patient who presented with features typical for critical pulmonary stenosis, was prostaglandin dependent, but fortunately had an adequate, and in fact a normal, tricuspid valve annulus, despite the fact the valve was dysplastic and initially the TR was severe. The balloon valvuloplasty has been durable. The gradient measure today across the pulmonary valve is 5, and there's no more than mild tricuspid or pulmonary valve regurgitation on echo. So he's done well from that perspective. interestingly, we'll get to this in a second, but in spite of his normal resting arterial saturations, he's got a grossly positive bubble study with right to left shunting at the atrial septum. And it'd be curious if you're an older child and exercising more strenuously to see what happens. I would predict he would probably desaturate with exertion. But perhaps let's scroll through the ICE images that we've collected so far. Judy's going to bring these up, and we'll just start with a survey. For those of you less familiar with ICE imaging, the intracardiac ultrasound probe has been introduced through the left femoral venous sheath. It's an 8 French sheath, and the probe rests within the right atrium. You'll see that fluoroscopically here later. And from that position, you're able to see a large swath of the heart. Rotation of the probe will move you in a plane that is tangential to the chest, and the probe can be tilted forward and backward, and it also can be tilted right to left. So you have basically 6 degrees of freedom of movement of the tip of the probe. So it's possible to get most of the views of the heart that are relevant with a view from the right atrium. And the fidelity is astounding. I don't know if it's making it all the way to you that way, but the image quality is super. So this first image you're seeing here is what's called the home view. So when you get into the right atrium, you look directly at the tricuspid valve, and then you know you're at what's called the home position. So there's the tricuspid valve. We throw some color on that, and you can appreciate the tricuspid valve regurgitation that's demonstrated there. And then just from this position, if you just rotate clockwise, you move into the left ventricular outflow tract. There's the left ventricle, the apex. You can see the left ventricular outflow tract and aortic valve there nicely. That small circular structure is the coronary sinus. And then if you even rotate a little more posteriorly, you pick up the plane of the mitral valve, and you can see the mitral valve is completely normal there, and there's a little bit of the left atrial appendage demonstrated there. And then if you rotate a little more posteriorly and then and flex, retroflex the catheter posteriorly, you'll come into the atrial septum. And go to the next one there. Here you're seeing the most inferior defect. So there's a defect that's along the inferior surface of the primum septum near the IVC orifice. And in this plane, it measures about 4 millimeters or so, but in other views, we get as much as 7 millimeters. So it's not an insignificant defect. And Judy, the next image.
Tom, can I just ask
here
you?
You're looking at the more superior. Yeah.
It's Ralph here. Just one quick question. Your main worry about this ASD is the current left to right, the later potential for right to left shunting, or a combination of both? And the main reason I'm asking because of this inferior defect, which may or may not be closable. If you're worried about right to left shunting, that becomes actually an important question, because then you really want to close everything.
Right. Yeah. Good point, Ralph. In this particular instance here, now at 7 years of age, our biggest issue is the ongoing right to left shunt, or excuse me, left to right shunting. He's got a dilated right ventricle, and in the face of this moderate TR, we're trying to get rid of that volume load. I think it's difficult to know how much impact this right to left component has in his clinical picture right now. We don't have any evidence of that. His resting saturations are normal. There have been no reports from the family about turning blue with exercise. As you said, I think that's something that tends to be a little later onset in the natural history of the right ventricular diastolic dysfunction that often accompanies critical pulmonary stenosis. So Judy, let's go back to our ICE images again, if we could bring those back up. So here you can see that the largest defect is in the usual superior portion of the fossa ovalis, a classic secundum defect. In most of these views, there is some retroaortic septum available, and in a couple of planes, it looks like it's fairly deficient. But let's go to the next frame here. I think we have. Keep on going. Got some measurements here. 7 to 8 millimeters with this upper defect. And then Judy, is there something that shows us the SVC limbus? There we go. Starting to get it. So here we're sort of sweeping a little more superiorly, and you can see that away from the immediate retroaortic septum that there's a fairly well-developed septum. In fact, once you go live, and I'll just try to show it that way a little. Okay, so we're live now. Okay, so can I see the live ice image? So I need the ultrasound image, please. Okay. So here, when I just go a little more rightward, and we can pick up the SVC, and you can see that superiorly there's a very well-formed limbus, and I think plenty of room to support a variety of devices. But our intent today is to use a non-self-centering device, the new to the United States anyway, the Cardioform septal occluder. And we really need to, as Rolf has said, we need to really try to see if we can capture everything. When we look at these measurements, the distance from the most inferior edge of that larger defect to the floor of the atrium is about 15-16 millimeters. So it's my prediction that we will probably have a small rim of residual shunt around that lower edge if we use a 30 millimeter device. And the largest Cardioform device available is the 30 millimeter device. Similar to the Helix occluder and with other non-self-centering devices, we try to achieve at least a 2-to-1 ratio of device size to defect size to device. And in this instance, a 30 millimeter defect within a 7 millimeter static diameter should be more than adequate to cover that well and hopefully reach the other end. We will have to flare the device on the retroaortic septum to some extent. I do have less concern about doing that with this particular device because it's softer certainly than the Amplatzer.
Tom, given that there are two,
Yes.
this huge difference or distance between the two different defects, would there any point saying you go ahead and just close with a smaller device, the larger of the defect, so you don't have to oversize, and then accept that the more inferior defect you may not be able to close and left with a 6 millimeter ASD that potentially you wouldn't cover with a bigger device anyhow. So you have a less bulky device sitting there in the larger of the two defects.
Mm-hmm. Yeah. Yeah, that's certainly an option. I mean, or two devices even in the current setting here. But I thought, certainly this is a device that we can deploy and evaluate and even set the lock. And if we don't like it, we can still take it out. But I've had very good success with this particular layout before, and have had several patients that we enrolled within the clinical study that allows you to use the device in more than one hole as long as you can capture everything. So I think that we'll at least try that, but your point's well taken. Judy, can you show the bubble study just to give people an idea? Because Ralph, you had asked about that particular question. What was our follow-up ACT, please? Okay. I want to see the bubble study. There we go. So you can see, interestingly, looks like he goes primarily left to right at the upper defect and right to left at the lower defect. Kind of interesting way that the blood streams in from the IVC. But you can see there's a fairly substantial baseline right to left shunt here as well. And then, of course, the left to right component consistent with what we saw on the color map. So the patient has been heparinized. In adult patients, I will often put both sheaths in the same groin, but we've separated them here in this younger patient. So the left-sided sheath is an 8 French sheath. I've upsized the right femoral venous sheath to 11 French to accommodate the delivery system for the GSO. I keep saying that the Cardioform device, and we can run it over a guide wire like a monorail. So perhaps we'll come around here and I can show you the device in a little more detail. I know a number of people in the room have been participants in the clinical study, but maybe not as familiar to some folks. A lot of the features are similar to the original Helix occluder. There is a double disc. You able to see that okay? Oh, if you can come down on it, that'd be great. So it's a double disc system just like the Helix, but the difference is that there's 5 wires in this frame rather than a single wire, which provides better coapting forces, and it brings the outer edges of the device into contact with the septum more completely. So early closure results tend to be better. I also want to point out one other thing about this device is that there's a small eyelet that protrudes out, and this comes out with the system when you set the lock. This pulls through, but it's necessary to have that in there to keep the eyelets, the left atrial eyelet, the center eyelet, and the right atrial eyelet in alignment as the lock loop passes through. And this is a little pokey, so you just have to be cautious that you've got this point out there. And if in certainly left atria of any size, it's not an issue, and typically you were pointed towards the left atrial or left upper lobe pulmonary vein, so this tends to not be a concern, but you just have to be careful about it and not indiscriminately push this thing forward in the left atrium as you're placing the device there. So we have this convenient little bath in the bottom of the packaging that wets the device, and then we'll also flush the delivery system from the handle here. Now, as opposed to the different generations of Helix devices where you had to manipulate the control catheter and the mandrels with your hands, it's all done within the confines of this handle. So the ease of use of this system has been improved considerably by this deployment handle. There is a lock that is used for packaging, this little plastic lock you can take out. This is how we set the lock, by pulling back on that red lever right there, but to prevent that from happening during shipment, they put that little lock, so you have to take that out of the way. And then to conform the device into the delivery system, you just pull back on this handle. So I'll just do that here, and you can watch my hands move, and it brings the device into the delivery system until you come all the way back, and then there's a detente back there, and you pull it all the way in. Now I'll go ahead, and if you could watch here, I'm going to push it back out. So watch the tip of the catheter there. There's the delivery system coming out, and there's that eyelet that I reminded you of. And then as you push the device forward, the left atrial disc will form. Looks like a Chinese lantern to some extent. And then the left atrial disc is formed. You come back to the septum with that, and then you go forward, and the right atrial disc is deployed like that. So it looks in many respects, when it's deployed, like a Helix device, but certainly a little more elegant. So once I have it in the loaded in, we'll just flush the device we'll flush the delivery system one more time. So we're good to go. Now, just like the Helix family, there is a retrieval cord attached to the right atrial disc. So if we decide to take the device out, you don't remove this red cap, or this little red tab right here. You keep that on. That keeps the retrieval cord locked in the handle, and then you would separate the delivery system right here. The outer delivery cable, or excuse me, the outer delivery sheath would separate here at this connector here, and then you would pull the system out from this direction, or from right here out. So hopefully that won't be necessary today. So Brian, you want to come on in here and take this. So there is a eyelet on the end of the delivery cable here. I don't know if people can see that, but there's a little eyelet here that allows you to follow a guide wire. I don't know that would be a big problem in this patient crossing without the wire, but I want to stay out of that inferior defect. So with the delivery system following the wire, it'll traverse an 11 Terumo sheath. A little snug, but not bad. And now we can watch the fluoro, please. Make the fluoro small and the ICE image large. So AP fluoro large and ICE image small. You could come off and just show the echo. Good. So
can we see the ICE
crossed,
image, Tom?
into the left atrium.
We cannot see the ICE image.
Steve, can you put up the echo image, Steve? Not my hands. Echo and fluoro. There we go. Super. So I'm going to go ahead and bring back the guide wire. Okay. So let me just clean up my ICE image here a little bit. So I'm going to just go ahead and start this deployment in the left atrium. Let's zoom up on the fluoro image one, just so people can see that a little better. Okay, so we're going to go forward here, and you see that little pokey thing. So we're just going to be mindful of that. And some of this is a little bit like an Amplatzer, where you bring the sheath back a little bit as you're deploying the system. Once the left atrial disc forms, like this. I brought a little bit too much out there.
So a question
There's
has
the
been
left
asked
atrial
as
disc
why you chose the 30 device, and I'm just going to repeat what you said before. You're trying to cover both defects with one device.
Exactly. That's the goal here. So the device is open in the left side. Now we have the center eyelet out, and you can see that a nice disc is formed there. So I'm coming to the septum. You can see on both images there that we have good capture. In the lateral view, you get a sense that the device is starting to conform nicely there. And then I'll just go ahead and complete the deployment of the right atrial disc. So now we have left and right atrial discs conformed here, but we still have the lock has not been set, so the device is still being constrained by the delivery system. So it tends to, like all stiffer devices, it tends to, in the ICE image, tends to rotate counterclockwise towards the IVC orifice. Let's go ahead, Judy, and throw some color on there, and we'll see what we see. I mean, right now, I'm not concerned about the SVC inflow because this device will flatten up when it, right here, it'll flatten up considerably when the lock is set. And let's go down. It looks like we have that larger defect covered nicely. You can see that left atrial disc is nicely up against the
Tom, can I ask
roof
you a
of the left
question?
atrium, but
Tom, what was the
there's not that much
distance?
splay, actually.
What was the distance of the atrial septum between the two defects?
15 millimeters, 15 to 16 millimeters, Bill.
All right,
So
thank
from
you.
the inferior edge of the larger defect to the bottom of the heart was about 15, 16 millimeters. So
Okay.
we'll see, but I'm hopeful that we'll cover nearly all that inferior defect with this device. So let's explore that lower septum just a little bit more. And there you can see that the device is actually kind of, I mean, it's not digging into the floor of the atrium, but it's right there. And there's, you know, you can see perhaps a little sparkle around that, but it looks to me like the device is covering pretty much all that inferior defect as well. Any other thoughts or comments?
It looks to me like you've accomplished what you want to do here. I mean, the idea with this patient's anatomy, you just want to have a complete seal of the hole because to avoid a right to left shunt along the IVC rim. And I would guess if you finish up with it, doing it this way, this is somebody that I would certainly want to bring back some kind of bubble study at some point in time to see whether it's closed or not. But I think it's important with this previous anatomy that we ensure complete closure of the defect. That's all.
Yeah,
We have a question here from the audience.
Yeah,
Go ahead.
point. This is
Tom,
this is not your garden variety atrial septal defect.
Tom, Gareth Morgan from London. How concerned are you that just the way you know the way the device will rotate quite a bit when you lock it? So how concerned are you that you're going to uncover that IVC defect when the device rotates on locking?
Well, that's a very good point, Gareth. I think that's possibly what will happen here, and we're not going to know till we try. So I suggest that we go ahead and see what it looks like. We still have the ability to retrieve this device using the retrieval cord if after we set the lock we're not happy with it. Once the lock is set, the device will actually conform to the shape that, or it'll adapt to the plane of the atrial septum much more fully. So to set the lock, and if you can come to my hands here, it's important to have the handle steady, flat on the table. You don't want to squeeze the center portion of the handle because that impedes the movement of the mechanism inside. But I basically just kind of keep my hand back here. And then to set the lock, we're going to draw this red tab backwards, and what that'll do is pulls the mandrel through the center and right atrial islet the same way the helix occluder, when you pull the mandrel out of the helix occluder, does the same thing. So this is just done mechanically for you. So I'll go ahead and record this so that we can take a look as it goes. And I don't know if you can see on fluoroscopy how the device rotates the plane of the septum nicely. And you can see the same thing on the ICE image. So let's go ahead and turn the color back on there and see how much of a shunt we've got left.
It almost looks like exactly what the previous question was mentioned, that the device moved away a little bit from the IVC end, and that's probably the shunt that
Yes,
you're seeing there.
It's no longer constrained. It's no longer pulled down. I think the amount of movement's small. I'm not going to fool with it too much. I can see a little flicker underneath there, right there, but you see it's sort of right at the margin of the device. Now the other thing that we've seen, and we've seen this with Helix, but we see it actually even more with this device because the coapting forces are better and the material is in contact with the septum earlier and more completely, is that small defects like that tend to resolve, sometimes as much as 6 months or a year as the endothelial process matures. We've had several patients that have left the lab looking like this that a year later have no detectable shunts. So I'm really quite happy with this level of improvement at this point. I suppose we could do a bubble study or something like that to look for residual right to left shunting. But I'm pleased enough with the position of the device that I'm comfortable releasing it with just what Ralph said earlier, that and Bill, you as well, that close monitoring of this patient will be important, and with his tricuspid regurg and other issues, we'll be watching him closely in any event. And if it turns out that we ultimately have to go back and deal with that, a very small device would take care of that nicely.
So let me ask you a question, Tom.
Yeah.
Just if you were going to approach this with two different devices, what would you do? How would you approach it in your hands?
I would close the smaller. I would close the smaller device or defect first, and I probably would use one of these. Either a Helix or a GSO, and probably a 15 millimeter device would more than suffice, and then capture the rest with a larger device. In a smaller patient, I mean, we've all done multiple devices. For the most part, it works. I hate to get a lot of bulk in the heart. We've all had and seen pictures and situations where the devices interact with one another, and a new defect can occur due to the erosion of the devices against one another. So, my preference when I can is to always try to do this with one device, and recognize that as this boy ages and his heart gets a lot bigger, going back after this smaller residual defect, if it's necessary, will be pretty straightforward procedure.
Don't
Here's
you
the
foresee
SVC.
Tom, if you were to close back in, you don't foresee any difficulties, given that there's not really much any room to the IVC putting the device in there? Do you think that it's straightforward?
Well, I think right. I think we could all get across there. I mean, I guess if it's real small, you'd have to question the necessity of the validity. To your point, the right to left shunting may require a different kind of concept about, or conceptualize the relevance or the importance of closing it. But for now, I'm really quite pleased with the result I'm seeing right here. And this is something else to point out here. This new generation Gore septal occluder, the right atrial disc lays down very flat on the superior limbus of the atrial septum, as you're seeing right here. This wasn't always the case with the Helix occluders, particularly larger devices in smaller patients. That leading edge of the right atrial disc would sometimes sail off of the heart a little, or sail off the septum a little bit. And we don't tend to see that with this device because it's improved coapting forces. So since we're ready to go ahead and let this device stay in there permanently, we have to release the retrieval cord. So to do that, we're going to take off this red cap. If you give it a little twist, it'll separate, and this becomes the puller for the retrieval cord. So as I pull this retrieval cord back, it's going to go inside this end here. This loose end will go inside the catheter all the way up to the right atrial islet, around the right atrial islet, and then back out. And so while I'm doing that, I am keeping an eye on the fluoroscopy just to be sure that I'm not in some way deforming or pulling the right atrial islet forward.
Can we see fluoro
And
too,
perhaps,
please?
yeah, let's do that. Let me profile this so you can see this occluder a little better. So this gives you a nice look at how flat these devices are and how the profile is such an improvement over the previous generation device. So I'm just going to keep an eye on this. See the control catheter is still right up against the right atrial islet. So as I pull the retrieval cord back, I'm getting counterforce by the control catheter that's up against the device.
You got about 2
And
minutes.
it's interesting sometimes. Good. Sometimes as you actually fully get this retrieval cord off, you'll see the device even lay a little more flat, but here it looks already pretty good to begin with. So now I'm completely free, and the occluder is pulled away. So I love the profile here, both on ICE imaging and on our fluoroscopic images.
So, Tom, before we have to leave,
Build
can we
since-
see color just one more time there, and so we can see what it looks like with everything released with color?
You bet. Yeah. Judy, you want to throw the color on there for us?
Tom, would you do are you planning on doing a bubble study at the end?
Yeah, I can do that for you. So there's that gap we talked about, and it, to everybody's point, it does look a little bigger at this point. It's probably 2 millimeters, 3 millimeters in that view.
All right, Tom, thank you very much.
Judy,
Congratulations.
Good job.
All right. Thanks, guys. We'll see you soon.